Welcome back, everyone. Let's now move on to the panel keynotes and discussions. To chair this session, I would like to invite Professor Raghavan, Professor of Mental Health and Director of Mary Seacole Research Centre, De Montfort University, Leicester, UK. He is also the Principal Investigator of MeHeLP India. Welcome, sir, and it's over to you.
Hello, namaste, good afternoon, good evening, wherever you are. Welcome to the final session of today, the second day of the Pan-India Conference on mental health literacy in urban and rural communities, and also the cultural of mental health literacy. Very warm welcome to all of you. And also we have an excellent panel, a jam-packed panel with great themes in relation to how we promote mental health literacy in various pathways, diverse ways of actually seeking people's opinions and comments and working with urban and rural communities. So you'll be prepared for a jam-packed session. So I'll introduce the speakers in a minute. Before I do that, let me just say some of the housekeeping bits and pieces. Do use the question and answer tab on the right hand side of your screen, and also do engage in purposeful chat and in the tab as well. So and also do visit our lobby, and there are a number of things there in terms of the short films and our galleries and also the MHLQ, the Mental Health Literacy Questionnaire, and you're very welcome to actually have a go at the MHLQ, which will be quite important for us in terms of your returns. So many thanks for joining us. Without further ado, I will start this session. So we have 5 speakers in this final panel session on the second day of Pan-India. So let me first welcome Anisha Padukone, CEO of LiveLoveLaugh, to the stage. And our second speaker this afternoon, or this evening, I should say, is Dr. Mangala. And our third speaker this afternoon is Dr. Sangeeta Goswami, and our fourth speaker this afternoon is Dr. Kaustubh Joag, and our fifth speaker is Professor Abba Singh. So welcome you all. Let me thank you for accepting our invitation and be part of this exciting dialogue and conversations around mental health and well-being and mental health literacy. So a very warm welcome from me and also from the whole of the MeHeLP team for your presence here. So let me just introduce the first speaker, Anisha Padukone. Anisha is the Chief Executive Officer of LiveLoveLaugh, a charitable trust founded in 2015 by actor Deepika Padukone. LiveLoveLaugh aims to give hope and every person experiencing stress, anxiety, and depression. Since joining LiveLoveLaugh in 2016, Anisha has played an instrumental role in the foundation's program and landmark campaigns. As CEO, she is responsible for implementing strategic recommendations outlined by the organization's board of trustees and exploring channels of collaborations and partnerships. She is also responsible for overall operations, including legal and financial compliance of the foundation, fundraising, donor relations, and various other administrative functions. Anisha has a graduate degree in psychology, sociology, and economics. Having experienced the ill effects of mental illness as a caregiver, she hopes to make a substantial difference to mental health. She is a member of the World Economic Forum's Global Future Council for Mental Health and has completed a program in strategic non-profit management from Harvard Business School and Ashoka University. She has a keen interest in sports and she has played golf for India. She has also published in the school-based program Instruct for people with good mental health in Scientific American and Lessons from 2020 making mental health priority for India in Forbes India, and also Why Investing in Adolescent Mental Health Matters in Forbes India. A very warm welcome to you, Anisha Padukone, to this session.
I think she's on mute.
You're on mute.
Am I audible?
Yes.
Great. I'm just going to share my screen. Thank you for the introduction, Dr. Yeah, there we go.
You okay?
Yes. Perfect. Is my screen visible and can everyone hear me?
Yeah. Yes. Thank you. Yes.
Yes. So thank you, Dr. Raghu and the entire team at the MeHeLP conference. I'm delighted to be here, and it's the first time I'm attending a virtual conference, so it's a little bit of a new experience. I'm going to take some time today to really talk about my organization, LiveLoveLaugh Foundation, and particularly stigma reduction initiatives. The genesis of our foundation really began in 2014 when our founder, Deepika Padukone, experienced anxiety and depression when she was at the peak of her career. Fortunately, she was able to get help from mental health professionals. And through that journey, she realized that she wanted to give back to society. One of the first things she did in terms of giving back was actually talking about her experience on national television. And that was the first time that a known face or a celebrity was accepting and talking about mental illness on such a large platform. And thereafter, she decided to set up the foundation to formally channelize activities with regard to mental health in India. So the foundation launched in October of 2015. The main aim of the foundation is to give hope to every person experiencing stress, anxiety, and depression. We work in a few core areas, primarily mental health education for adolescents, capacity building of doctors, access to mental health care through our rural program as well as on our digital platforms, mental health research and surveys that allow us to understand the landscape of mental health in India, and most importantly, where stigma reduction is concerned, public awareness campaigns. I'm going to take you all through some of the approaches that the foundation has really gone through in the last few years, and more importantly, some learnings just for all the viewers here who probably would also like to work in similar areas. So one of the most successful aspects of the foundation, in my perspective, has been nationwide public awareness campaigns. You can call them clutter breaking, largely because of the scale of which these were executed on. When I say nationwide public awareness campaigns, both of these campaigns, the first one on your left with the blue background is called Dobara Pucho, and the one on your right is called Not Ashamed, as the hashtag suggests. Both of these were conducted pan-India in about 6 or 8 cities, tier 1 and tier 2 cities across the country. And we had them playing out the video format as well as the print format in 5 different mediums, primarily print, hoardings or billboards, radio, television, and of course, digital, which includes our website and social media. So it was almost like a 5-prong approach where this kind of information was put out. Now, the first campaign, Dobara Pucho, which literally translates to ask again, mainly aimed to educate caregivers and the larger public to be able to be more empathetic or sympathetic towards persons with mental illness. During the time that we were actually filming this campaign, we realized that it was India's first large-scale public awareness campaign on mental health. There had really not been anything of the like before this. So while we have had, nationwide campaigns on AIDS awareness or polio reduction awareness. This was really the first of its kind for mental health, and it did far better than anyone expected. Largely because I don't think India had really seen anything like it before, and I'll come to some of the impact later on. The second campaign in 2018 called "Not Ashamed." As the creative suggests, involved persons with mental illness who really, I would say, had a lot of courage to be able to showcase their journeys. Again, for anyone who hasn't seen the videos or these campaigns, they're all on our website and YouTube pages, and I would really urge you to have a look at them. The second approach is what we call a digital first approach. Now, the foundation has always understood the importance and the need to be digitally enhanced as an organization. And therefore, when the pandemic came about, it wasn't really difficult for us to start using digital mediums. This is something we've started from a while ago, and of course, with the visibility that we have, we've tried to utilize that platform. So, two of our campaigns here, Stories of Hope, is really a platform where any individual can go onto our website and share their story, and this is then put out on some of our on our website as well as some of our social media platforms. The second campaign, again, something that we're very proud of, is called A to Z of Depression. What we're basically doing is simplifying certain concepts for a lay person to understand. For example, if a mental health professional is to explain what anxiety is, it probably will come across as very clinical. So while you want to, increase awareness or mental health literacy, it's important to understand that a common man doesn't necessarily want very clinical terms, because mental health in itself is already a very heavy topic. So what we did was come up with any word that represents all the alphabets from A all the way up to Z, and put that out in the form of a campaign on our social media platforms, which did really well, of course. And, of course, people had some of their favorite words that they chose. The third aspect is really our website. So a lot of the resources that the foundation makes available can be found on our website. The image that you see on the left in green is a database of mental health professionals that we verify internally, and basically we act as a link between those who are looking for help and professionals that are available. So you can log on to our website and put in a particular city, and if there is a counselor, a psychotherapist, a psychiatrist, or a psychologist in your area, you can set up a session with them. And similarly, on the right-hand side, probably one of the most popular pages on our website is a list of helpline numbers. Currently, we have about 15 helpline numbers, and they're pretty much all toll-free. Some of them are even suicide helpline numbers. So anyone who comes onto our website has access to all of these, and then, of course, the information is available. Now, an important point that I want to make is, one is to have a curated list or curated resources on a website. I'm sure all of us that have organizations have that. But probably more important than curating and putting together a website is to ensure that the information is constantly updated, whether that is basic information or resources or blogs. That's really what gets people to keep coming back. So you'll have initial visitors, and then probably the numbers will drop. So it's important to constantly keep churning out updated information and resources. The fourth property is called the Live, Love, Laugh lecture series. It basically aims to invite or bring influential leaders, personalities, those who really have an understanding of mental health or have had some kind of an experience. It's some of the world's foremost thinkers, influencers, and achievers coming and sharing their perspectives on mental health. The 2019 edition, of course, this was pre-pandemic, was in person. It was an in-person event. Our guest speaker that year was Dr. Siddhartha Mukherjee. He is an oncologist, a Padma Shri awardee, and most importantly, a Pulitzer Prize-winning author. And he talked about what cancer was in the US in the 60s with regard to stigma, and how India and mental health is at a similar journey, and the correlation between the two, and what one can learn, what one topic can learn from the other. The most recent edition, in fact, that was launched earlier this month was a lecture series with India's first Olympic gold medal winner, Abhinav Bindra, where he talks about his experience with mental illness, as well as embracing vulnerability and sharing some of his learnings along the way. Both of these videos as well are on our YouTube page. And if you all haven't taken a look at it, please do. It's really worth it. So this is also one of those aspects there where we try and normalize conversations. We bring individuals who have either had an experience or who understand mental health, just to spread the message that having mental illness is okay. It's just like having any other illness, and it encourages people to share and seek help if required. The last approach I want to talk about is collaborations. I think it's extremely important. Live, Love, Laugh as a foundation primarily focuses on partnerships and collaborations with like-minded organizations, and a lot of what we've been able to achieve has been through collaboration. So one of the ways in which we collaborate is, of course, with the government. We engage with them on a regular basis, and we try and ensure that through our various initiatives, launches, things like that, there is representation from the government as well. Then we have brands like Myntra. Now you may be wondering why, what can a mental health organization do with a brand like Myntra? So let me give you an example. Dobara Pucho, which was our first campaign, we actually got Myntra, we collaborated with them, and what they did was printed some of the print campaign material and inserted that into every package that went out for a period of 2 weeks during Diwali, which is the highest sort of sales that they have. So every person who received that was opening their package and parcel and looking at a mental health related campaign. So in a way, it could be somebody who opens that up and realizes that this is what I'm going through and therefore I need to get help. Or it's someone who has never heard of mental health. So there's different ways of creating awareness. So this was one of those slightly, innovative ways. We've also had a very long-standing equation and collaboration with NDTV, the news channel, where they've promoted a lot of our content and material to all of their viewers. Quickly moving on to some of the impact that we have been able to make. Through the school program, we've been able to reach out to about almost 2 lakh students and 20,000 teachers. We've reached out to about a little over 3,000 beneficiaries through our rural program, where we provide free psychiatric treatment, as well as over 2,000 doctors through our capacity building program. Now, coming to the impact that we've had with regard to the actual campaigns, all of which I've talked about. The NDTV interview was posted on our YouTube channel when the foundation started about 5 or 6 years ago. It's got about 1.6 million views, and it's probably one of the most successful videos on our platform, largely because of the relatability factor. The Dobara Pucho campaign has over 3 million views, so that's almost double of what this video has. And one of the interesting statistics was through a software that we used to identify the impact was before the launch of the campaign and subsequently after the launch of the campaign for a period of a couple of months, there was almost a 200% increase in editorial coverage with regard to mental health. And that is the the kind of scale and impact that large-scale campaigns can have. I have to, point out that yes, these campaigns do require a lot of funding, and I think we've been fortunate, to be able to find those kind of donors. But if you're able to, I think it's one of those things that really can create large-scale impact. Moving on to the Not Ashamed campaign, this was, of course, again, very successful because it spoke to persons with mental illness or those who are going through their own journeys. So we've had a reach of about 3.3 million on our YouTube page. And the one that's probably most interesting for me is the share the stories of hope or share story option that we have on our website that I talked about earlier, where if you look at 2018, we had about 62 individuals throughout the year sharing their narratives in writing. And last year in 2020, which was also obviously a year of pandemic, that number increased to about 116. So this is really what you can measure as a direct impact of stigma reduction. And hopefully in the years to come, more and more people keep submitting it. It's I think a way for individuals who are going through something, come onto that page and read, journeys of other individuals. That kind of helps them through that process. And lastly, a lot of these initiatives and everything that we've done over the last few years has led us to receiving this award. So Live, Love, Laugh, I'm very happy and proud to mention that Live, Love, Laugh is the first Indian winner of the Dr. Hisline Breaking the Change of Stigma Award. This was awarded to us in the year 2019. So the picture on the right is, of course, myself and the team who went to Belgium to receive the award. This is a global award, so it was probably that made it a little bit more prestigious. So I hope I was able to articulate myself well enough. And just to summarize, I think these that are really important where stigma reduction is concerned. The first one being consistency. We all know that this is going to take a very long time. So to be able to be consistent, and also just to understand that these things don't sort of change overnight. And I think at the foundation we realize that very well. And the second one is the kind of content you want to put out. You have to be really sure of what you want to put out, who's your target audience, what do you really want to achieve, and really look at it from that lens. So these two things I would summarize and say are very important when you're talking about stigma reduction. Thank you, and I hope I can answer some questions later on.
Come out of the share screening. Stops there. Right, thank you. Thank you, Anisha, for an excellent presentation, inspirational work by the foundation. And I think one of the important things is how successfully you have managed to digitalize the whole conversation around mental health and well-being. And I think kudos to you, and I think hats off to you. And I think it's an excellent idea, and obviously it's an example for us all in terms of how we can actually reach millions and also train millions of people, thousands of people around in urban and rural communities in India. So many thanks. We'll come back to you with questions later. So if you could hold on, please. Thank you very much indeed. So we have Professor Abha Singh with us. I think she's on the panel. So can we have Professor Abha to join us, please? Hello. Yeah. So our next presentation is by Dr. Mangala, and she's going to talk about mental health literacy through movie, the frame of mind experience. Interesting title. Thank you for that. And Dr. Mangala is actually from the Schizophrenia Research Foundation in Chennai, and she's got 25 years of experience in the field of psychiatry. After completing her medical degree from Tanjavur Medical College, she did a postgraduate training in psychiatry in the Institute of Mental Health at Chennai, and attached to the Madras Medical College to receive her diploma in psychological medicine. She is at present the Assistant Director and Media and Communications of the Schizophrenia Research Foundation, Chennai, and she has been a consultant psychiatrist for 18 years and is actively involved in the clinical services, including residential facilities, research, and community-based activities. She is a consultant in charge of the Bhavishya Bhavan, the residential unit of SCARF, with a 70-bedded facility for women and elderly men. She has developed a digital online course for sensitive reporting on mental health issues for journalists as part of Essence project, partnering with Sangeetha Bobal, and funded by the NIH, and service as a mentor for fellowships that are part of the project. As Assistant Director in charge of the awareness and communication, she is involved in organizing events to promote education and awareness about mental health related issues in the public. She conducts seminars and workshops to train people from a variety of backgrounds to sensitize them to mental health related issues. And this includes students of schools and colleges, and general medical practitioners, pharmaceutical professionals, self-help groups, and the public. She regularly participates in television and radio talk shows focusing on mental health issues. So a very warm welcome to you, Dr. Mangala, to our session this afternoon. Very a pleasure to have you here with us to talk about the work of SCARF and in relation to how we promote mental health literacy.
Thank you very much, Dr. Raghu, and thank you once again for having me here. And it was a very warm introduction. I think I must congratulate Anisha for a very interesting and excellent, impressive presentation that she made on the LiveLoveLaugh Foundation. So I think I'll move on to our experience with mental health literacy through films. So for those of you who don't know SCARF is a over 3-decade-old non-governmental organization based out of Chennai, the first of its kind probably in Asia, started by Dr. Sharda Menon, and we have a range of services: clinical, academic, research, and awareness. And I head the awareness area, and we also have residential centers. And SCARF was one of the organizations chosen by the WPA to run its anti-stigma campaign for schizophrenia in India. And Dr. Abdul Kalam, the then president of India, was the one who inaugurated it. And SCARF has a separate department for awareness and stigma reduction in its premises. So now, why a film festival? This is a question that many people asked us. So I think many of you will recall the Airwadi tragedy, where about 26 lives were lost because they were tied to pillars when a fire broke out and they had no way for escape. It was a big jolt, and it actually created a lot of conversation, dialogues around mental health and the way mental illness was handled by the public and the professionals alike. And it brought out a lot of changes in the law. And then SCARF went ahead to do a survey in the people of Chennai, which got reported in the media. And one of our important findings in the study was, 65% responded that their source of information was from movies and from television serials. So, and the impact, and especially coming from Tamil Nadu, where the film industry has given us 4 chief ministers to boast of. So you can understand the impact of movies and film personalities on the minds of the public here. So what followed after this survey was the first international conference on schizophrenia by SCARF happened in 2004. And as part of that conference, we had a workshop on media and mental illness, and we have some celebrities from the film industry who cooperated with us, and they participated on the day-long workshop. We had excellent participation from the student community in Chennai, and that was a very encouraging sign for us. They were very willing and keen to learn about what was wrong in the way movies were depicting mental health issues. And then there was a film festival for disability, which happened in the city. And when Dr. Tara and myself, when we attended the festival, we noticed that mental illness was glaringly absent. It was not represented at all in the Disability Film Festival. And then we decided it is time we have a film festival of our own, which is when Frame of Mind was conceived. And our aim was to use popular cinema to raise awareness and dispel myths, which means we have to identify good movies, movies which have done a good job on showing mental health in the right perspective. And each movie screening was followed by a panel discussion, which the panel consisted of both mental health and media professionals who could discuss both aspects of the movie, the mental health and the filmy aspects as well. And the other part was a short film contest where we encouraged anybody with an interest to make films. They could participate, they could submit an entry of under 5 minutes, and we had specific themes for every edition. This is a biennial event, so we were having it every 2 years, and there were prizes assigned for the short films that were selected, shortlisted, and screened. So the event was inaugurated by the then governor of the state, and you can see big people in psychiatry and the theater, Dr. Mogan Agashe, and the the governor, and that is Mr. Balamahendra, a renowned filmmaker, with Dr. Tara and Mrs. Garyali. So this is just a list of all the various films that we showed. It was a 3-day event, and every day we had about 3 films that were screened, morning, afternoon, and the evening. In between, we had the short films which came for the contest that were also being screened. So there was we tried to cover as many disorders as possible in every film festival. So there will be one film on a particular theme. And so we covered everything from schizophrenia, bipolar, dementia, depression, adolescent mental health, and then mental health in daily life, which also came up as a title for one of the contests in one session. And then substance abuse. We also used a few animation films like Inside Out and Trolls to set about a discussion on mental health and mental well-being among younger people. And we also screened a lot of documentaries, which were very compelling and very interesting to watch. And the competition section, we had it was always less than 5-minute films. It could be in any format. And the major criteria that we insisted day in and day out was a strict no to any stereotypes or any derogatory portrayal or a negative portrayal and unscientific content. And there was a reasonable prize money. Prices up to 1 lakh could be won, and there was no entry fee, and there were people who were sending multiple entries as well. So these are some of the themes that we used for the contest, starting with stigma, the myths, and then what do people understand by good mental health, the role of the family, mental health in daily life. And the latest one was last year in 2020, when it was coping with the new normal, and we had a very interesting array of films that we received from across the world. So how does this work? Usually it is the social media, the website, and posters and flyers to all the colleges, not only to the media and the film institutes, it's to all colleges across the country, and a lot of follow-up, and we sometimes, we go in person as well. And from our first film festival, we realized many of the participants who sent in their films, though their heart was in the right place, the entries were very, very stereotypical, again, propagating the myths, and it was not what we wanted. So we decided that it is not enough if we just announce a contest. So we decided to have workshops in all the major cities in Tamil Nadu, and whichever city would have us. So the students were given a sensitizing session about what mental health is and what we would like to have in the films on the theme and on mental health in general, which was very beneficial because the subsequent entries were better in quality, and we started getting a lot of international entries as well, right from the first edition. And the latest, we had about 50% of the entries were international during the lockdown. And the technical quality and presentation has been improving, and we have some of the movies, the way they have interpreted has, it was very interesting to understand, and it gives us it improves our own understanding of how people perceive mental health, and it will help us to evolve in the way we communicate mental health related concepts to the public. And it is a definite thing to note that the grasp of mental health concepts among the youth is definitely improving. So these are just some of the pictures from the award ceremony. So what was very good about these festival was definitely people who attended the festival had a better awareness. They were able to understand certain issues that were being discussed in the films better. And we actually had a select group of audience, who became regulars for the event. And the media interest that this festival generated was also very encouraging. It got reported in a lot of newspapers and magazines, and the support from some of the film personalities was excellent. So we were very encouraged, like the presence of film personalities in such an event is definitely bound to draw crowds, and we were more than happy to have more film personalities. And over the years, we have noticed the discussion that happens after every film viewing gradually improved, and there were people who were able to come forward and acknowledge that about their own mental health issues or about their family members problems, which we felt was a very, very important thing. People should be able to come forward and talk about their illness, and it is not in private. They are able to do that in front of an audience, and we thought that was it was very happy for us to note that that kind of a change was happening in the people who were attending the festival. So then, of course, challenges are always there. Finding films with the right content has been a challenge. In the very first edition, we had we had movie in Malayalam, in Hindi, in English, but we couldn't find a proper movie in the local vernacular Tamil. So these were all, it was pointed out by people, like, why are you not having a Tamil film? So we couldn't find a right film with the right content. So all this became challenges for us, and we tried to keep a good blend of Indian and foreign films, because I think we need to promote mental health in our cultural context, which is very important for the people. And if there is one language which has been always giving us good films on mental health, it is the Malayalam film industry. And I think we can hold a 1-week film festival with the kind of films that they make on mental health. And the variety is definitely needed so that we can hold the interest of the audience. And there's a big challenge in involving media persons as panelists, to get them to watch the film and come and spend the time. All those were challenges, because with busy people, it is not that easy to get them involved. And for the competitive section, as I said, it is getting them to understand the concept of mental health and to move away from stereotypes of violence was a bit of a challenge. In fact, now I interact with a lot of young filmmakers who come and discuss their potential stories for a movie, but then if there is a mental health content in it, and then they are very unhappy when I tell them that some of those things that they are trying to say is not okay, but they're open to modify their story so that the right scientific content goes into the depiction. So that is a very encouraging sign. And as I'm sure I don't have to say this, getting sponsors is a big challenge. And we also need a very responsible jury, and we have been very lucky in that aspect. We have always had an excellent jury, and Dr. Mitchell Weiss, who's the former professor from the Institute of Tropical Medicine in Switzerland, he has been our chairperson and a main juror who has shaped the event all over the years. And so he is one of our, it's that man standing third from left. And we have Dr. Mogan Nagashe, who has also been a big source of inspiration and support for us. And the other gentleman there is Dr. Ashok Pai and Dr. Rangarajan. Yeah, and we have our sponsors who have also helped us a lot. But besides the film festival, I think if there is a good media coverage of the event, a well-reported article is as effective as the film festival itself, because all those key points that are discussed get covered in a good story, and that remains with the readers for a longer time. So that was a very important role that the press played in for the success of Frame of Mind. So these are some of the clips. So now we have a good collection of short films. So what do we do with all those shorts? We use them for teaching mental health for people who come to us, for internship, or students of social work, psychology, and other areas. Like we go to schools for doing sessions, and we use these films for making people understand what mental health is. It's more interesting. And the best use so far has been, what you see there in that image is the back of a bus, and that is our mobile telepsychiatry unit in a remote place called Padukone, which is about 300 kilometers from Chennai. And after the consultations are over for the day, the bus is parked in a bus stand in that nearby village, because we have a clinic in 2 villages every day, so the bus keeps moving. So at the end of the day, the bus is parked, and then these films are screened, and it has generated a lot of interest, a lot of awareness, and people come with queries, and they come seeking help after watching these films. So that way, these short films have definitely served that purpose. And it is also available on YouTube, and so more people can view it if they want to. So Frame of Mind was the first of its kind in India, and following that, several other film festivals have come up, and that is a very encouraging sign. We are very happy that so many film festivals are happening in India on mental health. And in fact, we had a couple of inquiries from other parts of the world too. So what is the future? We would love to make it an annual event, but for paucity of funds. And we would like to transform this into a festival with only short films and do away with the feature films. So that way we might be able to screen more short films, encourage more people to participate. And also we would love to involve the audience as part of the jury. So all those things are part of our plans for the future, but we are working on how we can make it happen. So those are just some of the pictures from the last event. Was a virtual film festival where we had only panel discussions about films, and we had the short films alone that were screened, but it still had a very good response among the public. We had a good audience who watched the discussions, the panel discussions. And this is the building out of which we work in Chennai. Thank you for your patient listening.
Thank you, Dr. Mangala, for an inspirational talk on the use of films and in improving mental health literacy. And I like the concept of movie on a bus. And I think that's nice to actually have that. And I think it's an important medium. I think film is actually an important medium, and how we must actually, because obviously at the moment, I mean, both in the Western context and also in the Indian context, films only tell a different image of mental health and mental ill health. It doesn't actually give the right image of mental health and mental ill health. So I think it's important. I think there is also we should also be working about educating the media people and the film people in relation to what is mental health and mental ill health. So I think it's important. But I think we also been in that pathway. We also have produced a number of films, short films, which is actually available on our website. And I think we also have this mental health literacy questionnaire, which could be used for evaluating the mental health after watching after the film's been, because I think we need to look at the knowledge and attitudinal shift of people. So I think that could be something that could be taken on board as we move along in terms of where we go next from here. So many thanks for that. A very inspirational, a lot of activities, and I'm sure we're happy to collaborate on the next film festival.
Oh, that would be great. Thank you.
We come back to you on that. Okay, many thanks. Our third speaker is Dr. Sangeeta Goswami, and Dr. Goswami is going to talk about positive mental health work by MindIndia. Dr. Sangeeta Goswami is the first consulting psychologist to have set up an independent counseling clinic in 1996 in Assam, situated in the northeast region of India. She, along with Mr. Abhijit Goswami, established MindIndia, an institute for positive mental health and research in 2006. MindIndia is an endeavor dedicated to the cause of ushering the benefits of positive mental health and well-being to the general population, with special focus on Northeast India. Understanding the need for trained counselors at the grassroots level, Dr. Goswami runs 2 short courses in counseling skills under Hindiki State Open University, Assam, and Barefoot Counseling, jointly certified by the Public Health Foundation of India and MindIndia in 2021. Apart from the courses, Dr. Goswami is successfully running a comprehensive multidisciplinary mental health wellness center under MindIndia and has been an advocate for creating awareness on positive mental health and well-being and reaching out for the last person in the last village. So she has 25 years as a service as a counseling psychologist, and she has undertaken a number of activities in the field. And accidentally, I also worked with Sangeeta Goswami on a global public health funded program from the University of Leeds, where we are collaborators as well within that research funded by UKRI. So, Sangeeta, a very warm welcome to you. And
thank you. Yeah, thank you so much. Thank you, Dr. Raghu, and thank you to the organizers for inviting me here, and absolutely privileged to be among such eminent speakers. And it has been so interesting to look and watch Anisha's work and Dr. Mangala, of course, Scarface. We have studied while we were also studying. We used to look up the scarf, and a lot of inspiration that you have given to all of us. So we always appreciate Scarf's the work and the team that is doing there. So I'll just quickly try to share my screen. Am I visible? My presentation? Is my presentation visible?
Yeah, thank you.
Yeah.
Yes.
Okay. All right. So I'll just expand it. Okay. So as Dr. Raghu has said, that we started in 2006, and prior to that, when I completed my work as a counseling psychologist, my training from Vellore, and I came back in '96. You see, I'm based out of Guwahati, Assam, and that is the northeast of India, which actually consists of 8 states and more than, I think, 220 ethnic communities. So it's a very big community that we live in, and if you look at it, there is a lot of interconnectivity when we are talking about these 8 states. And sometimes they say that we are, a small part of India, but I think we are a major part of India, and that is what made me come back and say that let us do something more out here, because there is a need here. And the need was, number one, the awareness was very, very poor during that time. Not that I'm saying it's fantastic right now, but a lot of organizations have come out by this time. And as we started working, we understood that what was important is that not to look at treatment, rather than also look at the preventive part of it. And when we talk about mental health literacy, it can be in so many ways. And I think one of the most important ways to look at it is the changing of the attitude of that person, of how I look at myself and how I look at the community, and whether I am able to have a well-being, a feeling of well-being with myself and the community. So this is what has been a vision of Mind India, where we say that we want to have positive mental health and well-being for all. And the mission is to enable people to choose change. We always believe that a person has the capacity in himself or herself to select and choose change. It is that just that somebody just needs a little bit of a push. This is what we're doing. We need to facilitate so that we can enhance the quality of life of that person. So if I look at the strategy that we have, I call it as prevent, prepare, and pursue. So we try to prevent any detrimental influences which may lower positive mental health and well-being for people. Try to prepare people to face any challenges in their life by equipping them with, especially with psychosocial skills to enhance resilience. Now we not only talk about resilience nowadays, we also talk about anti-fragility, right? And I think this is something very important, because it's important to move on in a more positive note, and to thrive and to able to accept as we are and what we are, and move towards more of self-actualization. Pursue well-being by enabling exploration of new opportunities, avenues, and activities within the community. So we work a lot with the community too. And as I go by, maybe I'll be able to share a few of the work that we have been doing. If I look at the thematic areas that we have, one is called counseling and well-being, where we have this wellness center, a comprehensive multidisciplinary team looking up from children to adolescents to elderly care. We work a lot with children and adolescents. We do a lot of school mental health work, career assessment and counseling, institutionalized wellness program. We have a few wellness centers in a few distinguished institutions like Indian Institution of Information Technology in Assam. And we try to handhold a lot of organizations who are grassroots level organizations and provide technical support on counseling and well-being. And how we do it is basically by two educational or training that we have. The first one that we have, the course that I established was on counseling skills. Again, why counseling skills? If you have done any course or training in psychology, or especially in psychology, you will understand that we know a lot of theories behind what is counseling and how we need to do it. But when it comes to the practical exposure and the practical way to do it, a lot of times we miss out on the skills. So this particular course, which is a 3 month course, which is under the Open University of Assam, we are a study center there, and this teaches us mainly on the skills. And this has given a lot of exposure to students from the field of psychology, sociology, education, social work, and allied health sciences. And happy to share with you that more than 90% of my alumni and students, they are employed very fruitfully in, especially with schools and NGOs. While when COVID hit in, and we all did, as we all did all over India, we started going online more, because we said that we need to still reach out to people who we can. But if you, again, what has happened, when I was looking at it, I understood that one of the biggest challenges that we have in the Northeast is connectivity, because of the kind of terrain that we have here. We have got plains, but we also have the hills. So a lot of times we are not able to reach out to mental health specialists, especially from the district levels. So this made me think about that why not do something more where we give the basic skills of counseling to people in the community level, who will be able to provide the psychological first aid that is necessary right now, and also help us to network and to connect the people to mental health specialists. So this is something that I had done earlier with women groups, where I had trained them on barefoot counseling to mitigate violence against women and children. And so with that concept, I reached out to PHFI, and they were very happy to be part of this program. And now we have this course which will go online from next month or so. But we have already started with the on the workshop mode, and we have been able to reach out to a lot of NGOs in the grassroots level, who are actually talking to women, to children, and to young people. We do a lot of work on child rights and child protection. We have been working with UNICEF for quite a few years now, more than a decade. And our emphasis is also on youth development program, where we talk about not only about soft skills and life skills, but also how to enhance yourself. And it is more focused on the self. And not only that, we also thought that it is important that we make them market ready. So employability skills is also something that we keep on talking, when we are doing this kind of youth programs. Again, focusing on Assam and the Northeast, we have got brilliant students here. They are wonderful. They are able to academically really excel. But when it comes to actually putting themselves out there, it is very difficult for them. It may be also because of the lack of exposure that they have. And so the combination of how to make them market ready with soft skills, life skills, and employability skills is the gamut of interaction that we do during these programs. Then we also talk about elderly care interventions. We do dementia screening and things like that, so that we are able to again go more from the preventive perspective. So this is where our multidisciplinary team works. If you see, this is the front of MindIndia. We have also alternative services like physiotherapy, yoga, mindfulness practice. And it's also because when we talk about well-being, and if we are able to just talk about the core mental health issues, a lot of times we miss out on bringing people together, and awareness will only be enhanced if I'm able to give them something more like a bouquet, and you can select from there what you want to select. But the core element of making them understand about mental health remains the same for us. uh, Career assessment is something that we do online as well as offline, and very recently with a very big public sector, which is called Oil from Assam. We have worked with them, and we have reached out to more than 4,000 students, and we have given them not only on career assessment and counseling, but also on emotional support along with academic support during this time. This is what we have been doing for our KK Handic education. This is the one that I talked about. And we always believe that catch them young. And our emphasis is that is why on teachers' training, on kindergarten teachers' training, so that we can say that if we are able to have that intervention, the early detection intervention. So we look at a lot of developmental delays, and we also teach the teachers and parents how to understand and recognize the red flags in children and young people. It was a challenge for us to bring, a psychosocial element into the formal education system. But with the support of UNICEF and with the Rashtra Madhyamik Shiksha Abhiyan, we were able to put in life skills education for class 9 students in 4,500 schools, which are vernacular schools in Assam. And not only that, we also reached out to the residential schools where children who are orphans have been taken up in these schools. And this was an impact that we are very proud about, because it reached out to more than 45,000 students during this time. Some of the universities also which are with us, one of the Northeast universities is Mizoram University. So they are with us for some residential programs also. And these are the ways that we teach them about the counseling skills and about life skills, because it is very hands-on. So if you have experiential learning, which is the emphasis that we have in MindIndia, it is more about building yourself, then only you will be able to build a community. Some of the work that we did as Wellness Carnival to enhance awareness on mental health. These are from the district level where we talked to young people around 25,000 plus who said that this is what we want. These are the ideas that I want to share about mental health. And we asked the DCs of the district collectors of these districts to come and listen to them so that they understand their concerns and how they want to resolve it. And it was very interesting because the young people, they not only talked about the concerns, but they also gave the solutions to it, that this is what we need and this is what you need to do for us. One of the manual which I had developed on quality caregiving in the context of HIV, this is also related to basic skills in counseling, which is now running in Southeast Asian countries as one of the technical guides for counseling there. So social welfare, Anganwadi workers also, again, we looked at the developmental delays and we saw that in the developmental delay checklist that they used, mental health was neglected. So we tried to incorporate some of the elements of mental health, of how to find out about the developmental delays in mental health among children. And we had worked out with them for more than 100 Anganwadi centers. Community engagement, yes. One of the struggles that we have is that we need people who understand different dialects, because when we reach out to them, we have to speak in their language. So that is the way we will be able to connect with them. A lot of awareness was conducted during mental health because they were not able to understand what to do, where to do. And domestic violence had increased, children being beaten up, there was corporal punishment also happening. So these were some of the areas that we were looking at. And we also tried to look a little bit on the livelihood area. We trained up young people and we gave them an idea of how to develop. If you can look at that picture below, it is we had distributed hands-free sanitizer and wash drums for them, and we had called it a Swachh Man Swachh Desh. And this is something that we trained them on. This is the kind of structure that we thought will help them at least to enhance something during this COVID times. Young people reached out to a lot during this time, and we used to have a physical share circle from MindIndia along with Agora, which is a youth-led space. But when pandemic came, we felt that they did not have any space where they can talk. And so we thought that let us have a safe space where they can share. And this is how the sharing circle over Zoom, with very limited number of young people, and we will only allow other people to come in only by invite, so that they feel that it's a safe space for them to share. And I think it was very liberating for a lot of young people to talk about it. And suicide was one of the biggest elements that had been reflected during that time. We started off with a suicide prevention helpline also, and very graciously, our consultants gave their pro bono time for this particular cause. We always believe that if you are training up the women, then you are also automatically looking after children and adolescents. So this is how we talk to the women group. Now, we have recently started off with another capacity building of women self-help groups on awareness on substance use disorder, alcohol and well-being, and which is supported by University of Leeds, UK, where Dr. Raghu said that we are working on those similar projects there. And we are going to reach out to more than 200 members of the self-help groups from the district levels. And they wanted to understand what we need to do for our children to make them more happy, to have a quality of life. And those questions are very interesting for us, because we thought that they will ask certain basic questions to us, but no, they went very deep into it. Some of the work that we do is very eclectic. We use different kind of techniques. These are the art-based therapy for emotional healing. Some of the pictures are from there, from the different workshops that we do. This is again with a lot of dupattas which has been there, that has been used. So we use any kind of technique which we feel can be related by people. And we use a lot of theater techniques for emotional healing. And this is how we have been able to make people understand that it is okay to talk about it. Let us share. What is more important is to share, and it is okay to be vulnerable. Working with UNICEF, we have reached out to a lot of tea gardens in Assam. You know that Assam is very famous for its tea gardens, and there are the adolescent groups in the tea gardens. And one of our first work that we started in 2010 with them was to empower adolescent girls through life skills training. And there were a lot of fantastic stories that came out from there where they were able to gain confidence. One of the biggest challenges that was there was school dropout, elopement. I think elopement was something very, very natural to them. As they come to the age of 14, 15, they start thinking about marriage, and they say, okay, which is the best way to go about it? How do I find somebody who is very suitable for me? And so to think about the future, everything was very short term, but now they were able to think long term. A lot of these young girls that you see in the picture, now they are in colleges and they're studying and they are getting into vocational courses. So the kind of content that we had, and we addressed these issues were education, nutrition, injuries and violence, including gender-based violence, substance abuse and misuse, mental health and emotional well-being, gender equality. We talked about menstrual health and hygiene, which is one of the most important areas that we thought was very, very necessary. And we started from the age group of 13 onwards till 18. And overall, that during that time, it was around 80 gardens. Now we are working again with them. And this time we are providing with them on mental health and psychosocial support, and which we call it a samartha. Mental health and psychosocial support, we are doing it on a peer group, peer leader mode, so that they will be able to understand. We are calling them Mon Hoki in Assamese. So they are the friends of the mind, which is a very literal translation that I'm giving to you. And again, we are going to reach out to around 12,000 indirect beneficiaries, and 300 peer leaders are being trained in the manual that we have developed from MindIndia. One of the areas that we have been working on in research and development and with our research collaborators from University of Leeds and Brighton was on talking about the voice of youth from resistance and recovery from addiction. This was a 2-year program that we had. And a lot of beautiful movies had come out, films which have come out. I think I can also share that with Dr. Mangala also, because, and we would love to include all that with other organizations, because these were the stories that were told by recovering addicts of what has been happening to them. And so this is with Anup's permission, I am putting his picture up, and he is a recovering addict, and he told his story after he talked about the movie. He shared his story, and these were the impact events that we did very recently with them. So though we have the challenges of lack of trained manpower, connectivity, awareness again, because a lot of people do not believe in funding the Northeast. Somehow they feel that maybe the impact will be not as much. But we have seen that whatever work we have done from the field, our field community is very, very committed. They're extremely sincere, and they have that will to do something good about the community. And it is just that we just need to give them a helping hand, and they will be able to help themselves. So with this note, I thank you for giving me this opportunity to share about our work, and very good evening to all of you. Thank you.
Thank you, Dr. Sangeetha, for that talk in relation to how the community engagement in Assam and that range of work that you do with young people and the families are very important in actually promoting mental health literacy. So we'll come back to you with the questions again. So we have two more speakers. I have to limit the next two speakers to 10 minutes each, if I could, please. So our next speaker is Dr. Kaustubh Joag. Dr. Kaustubh is a psychiatrist and a senior research fellow at the Center for Mental Health Law and Policy and a project coordinator for Apniyata. He has been trained as a psychiatrist and has also worked as a consultant psychiatrist. He has worked on Apniyata since its inception, first as a co-principal investigator through the proof of concept stage and as a principal investigator for the transition to scale stage. He also leads a social franchise model for this project in partnership with MAVIM. Additionally, Dr. Kaustubh coordinates the Center's International Diploma in Mental Health Law and Human Rights and is practicing psychiatrist. He enjoys music, sleeping, and Bollywood movies for his free time. Over to you, Dr. Kaustubh, for he's going to talk about building community capacity for mental health and well-being.
Thank you. Thanks, Dr. Raghu, for a warm introduction. I will try to stick to time. I hope the screen is visible so that I can move ahead.
Yes, it is.
So, thank you. So, I'm going to just share our experience with our intervention called as Atmiyata. This is a community mental health and social care intervention. We are running this intervention since 2013, and it's almost 8 years since we are going through this intervention. Happy to share with all of you that Atmiyata has been recognized by the World Health Organization as one of the 25 good practices for community outreach mental health services in the world. Now, coming back to the intervention, why Atmiyata? And we always pose these four issues from a rural mental health point of view. One, I think we all know that mental health is a huge public health concern. There are inequalities in accessing mental health care and treatment. There is a huge rural mental health care gap, as well as there are different or common psychosocial stresses which rural communities go through. From a public health point of view, we know 1 in 10 people suffer from some form of mental health condition in India, which can translate into 150 million people out of our population, and that's a huge number. But 8 out of 10 people in India do not have access to mental health care and treatment. When I say care here, it's more than a medical treatment, and care means the psychological as well as the social care. And almost 80% of people do not have access to this care. So this leads to what we call as a rural mental health care gap. We know that there are significant difference in the availability and quality of mental health services in India among urban and rural areas, as well as the gap is due to different factors. On demand side, there is a stigma, discrimination, different social and structural barriers which exist in our communities. While at supply side, there are insufficient trained mental health professional, quality of services are not very good, services are exorbitant cost, they are very far and distance, they are not easily accessible. And most importantly, most of the mental health services still have a biomedical approach. So that leads, and these are some of the reasons which leads to a mental health care gap. Talking about stressors, there are these different stressors what we have observed in the rural communities. Again, most of us know, like poverty, unemployment, barriers to accessing education, discrimination on gender, caste, class, and religion, and so on. So with this background, I think what is Atmiyata, or with this kind of a context, we thought to innovate an intervention which is rural based or for rural communities, built by them, for them, and provided by them. So I'm going to talk about in very briefly about Atmiyata. It's a community-led mental health and social care program, an innovative solution which basically builds on existing social capital by working with community volunteers. It's a sustainable, low cost, and a high impact model. Atmiyata, as word suggests, is basically translates into shared compassion. So these are the core values of Atmiyata. As I said, shared compassion, which is equivalent to Atmiyata. Empathy, which we use in a psychological services or psychological counseling framework, is again synonymous to Atmiyata. Volunteerism and participation, connectedness, and reaching out. So these are some of the core values which we go ahead with in the communities. Another kind of a context of Atmiyata is this is a WHO service organization pyramid for services for mental health. As you can see at the top of the pyramid, there are institutional facilities like long stay general hospitals and community services, as well as the primary care services. And as you can see the arrows at the two ends, the frequency of need increases as you go at the bottom of the pyramid, while cost is low at the bottom of the pyramid. And it's exactly the reverse, is that at the long stay facilities, the cost is high and frequency of need is low. And that is where Atmiyata fits in, which we call as informal community care. Atmiyata tends to fill this gap with informal community care in this mix of services for mental health. Talking about our reach, currently we are working across 524 villages in Mehsana across Gujarat. In Gujarat, Mehsana is a district in Gujarat, so we are covering entire district. Uh, before Mehsana, we have pilot tested Atmiyata intervention across 41 villages in Nasik, that's in Maharashtra. Uh, in Mehsana currently, annually, we reach out to around 20 to 22,000 beneficiaries with common mental health as well as severe mental health conditions. Uh, Growing further, currently we are also expanded Atmiyata intervention in partnership with Ambuja Cement Foundation across these 4 states. As I mentioned here, numbers of the villages which are in different states and different blocks. So how does Atmiyata work? Largely, the team structure, which is largely, this is based on the field, starts from project manager, community facilitator, champion, and mitra. I will try to just give you a highlight or briefly tell you what exactly each of this person entails and what is their role is. This is just a structure again. Project manager is trained by program manager, community facilitator is trained and supported by project manager, champion is trained by community facilitator, and similarly, Mitra is trained and supported by champion. But at the core of Atmiyata intervention is champion, and I will explain about who is our champion. So this is one of our champion, Maksuda from Kamli village, Mehsana. Here is her quote. I'll just wait for 2 seconds for you to read. So moving on, champion is a village-based volunteer. So I think that's where the volunteerism and participation comes into force and tapping onto existing social capital, as I earlier said. Champion has four main activities or roles to do for their own community, for their own village. First, they identify persons who are in distress and provide 4 to 6 counseling sessions to them using evidence-based techniques. Then they also identify people who have a severe mental health conditions, and then they refer or refer them to a public healthcare facilities. Parallelly, they also facilitate access to social benefits. As we know, there are a lot of government benefits for people with psychosocial disabilities or vulnerable and marginalized population on employment, on disability pension, and so on. So champions facilitate access to these social benefits. And lastly, champions use smartphones, and smartphones are loaded with films. The films are based on everyday social stresses or social determinants of mental health. And these films we use largely for building community mental health awareness as well as reducing stigma. And our modality is champion uses the smartphone to narrowcast films. When I say narrowcast, that means they show these films in a group of 2 or 3 or maximum 4 people and actually discuss about these issues like domestic violence, unemployment, addiction, and so on. So moving on. Sorry, so this is a champion. You can see the showing the film to the community people. The next set of volunteer or next layer in Atmiyata intervention at a village level is what we call as a mitra. Mitra is really the eyes and ears on the ground for champions. They are identified and trained by champions. Largely, Mitra's role is just to link people who are in distress to champion. And largely, this is the concept of Mitra is largely to enable reach within communities, in rural communities at the village level, so that we can break social as well as the cultural and geographical barriers. So these are some pictures from the field. Next part, or the next in the structure, is a community facilitator. So this is a project staff. They are paid and they are full time with us. The role of community facilitator is largely to identify, train, mentor, and support champions. Then they liaise with lot of local stakeholders from the at the village level as well as at the tehsil or a taluk or a block level. They regularly travel to villages and talukas, and they have an application which is loaded on their mobile for supervision and monitoring. But their key role is to basically identify, select champion, train them, mentor them, and support them. So that's their important or the key role. So this is one of our champion who is talking with the beneficiary. The last in this structure is the project manager. Project manager, we have a conceptually a person who basically can monitor or mentor around 7 to 8 community facilitators in a district. They liaise and collaborate with internal as well as external stakeholders. They conduct regular field visit. They are largely assigned for quality assurance and fidelity, as well as they document and access the app for monitoring and evaluation. So this is the picture you can see. This actually in the white, as you can see, Shailesh Solanki, who used to be our project manager. Unfortunately, we lost Shailesh Solanki in April, at the end of April 2021 due to COVID, and that's why we always, I feel that this is in memory of Shailesh Solanki. Moving ahead, just to summarize, this is the structure as I explained for Atmiyata intervention at the district level. Atmiyata core team, as we call it, including myself as well as my colleagues, my colleague Jasmine Kala, and the other team members, largely manage project managers and train them as well as mentor them, and that's how the cycle or the structure flows in. Talking about outcomes, we actually from 2016 to 2019, we did a randomized control trial called as a step-based cluster randomized trial. It's an innovative design for implementation research. As you can see, we had a baseline 3 month and 8 months data. At 3 months, our odds ratio was 2.3, as well as at 8 months it was 3.2. What does it mean is that at 3 months, people with common mental disorders in Atmiyata group have 2.3 times higher likelihood of improvement as compared to those in usual care group who have not received Atmiyata intervention. So the likelihood of somebody who has a distress or depression or anxiety getting better is 2.3 times higher at the end of 3 months. I think the great part for us, or the real significant key finding, is at 8 months, not only this recovery sustains, but it is more than at 3 months. So if you can see at 8 months, the recovery in Atmiyata group is 3 times higher than the usual care group, which is again who have not received Atmiyata intervention. So that's the kind of a significant kind of a impact of Atmiyata or evidence from the evaluation perspective. We also did the economic evaluation of Atmiyata, and what we know now that Atmiyata is a sound investment. So with every US dollar one invested in Atmiyata intervention, there is a 9.35 US dollar return in terms of improved health and productivity of the individuals. So with this, I come to a last or end of my presentation. These are the silent features we always feel about Atmiyata. Largely, when we go to rural communities, we uses a distress paradigm rather than illness paradigm. I think that language is very important when we go to communities and use their own language or co-design our intervention along with communities. I think that's very important. Our aim is to provide equitable access, and that is how our, if you can see, our breakup of volunteers at the villages is represent population or communities. We optimizes existing social capital within communities. We try to reach out as maximally to vulnerable and marginalized members of the community. And as I earlier said, most of our capacity building material, intervention, as well as on day-to-day basis, the material is developed in consultation with community members. The team is gender equal. and we prioritized of marginalized groups. So with this, I will end my presentation. Thank you very much for patient hearing.
Thank you very much, Dr. Kaustubh. That was an excellent narration of how the Atmiyata project actually works. So I heard a lot about it. So I think it is important to bring that clarity in terms of the simplicity in which it actually works in terms of supporting people. So thank you very much. I think we'll come back to the questions. I know the time is actually tight. So Professor Asha, if you could limit it to 10 minutes, your presentation, then we will have some about for 5 to 10 minutes to take up some of the questions and discussion, if I may. So our final speaker is Professor Abha Singh from the IILM Center for Emotional Intelligence. She's an ex-dean and faculty of Arts and Humanities and Journalism and Communication and Social Sciences and the Director of Research at the Amity Institute of Psychology and Allied Sciences in Amity University in Uttar Pradesh. Dr. Singh is a professor of psychology and behavioral science, and she's a gold medalist for her doctoral research. Professor Singh has more than 24 years of professional experience in teaching and training and research in psychometric testing. And she's also co-author of book chapters and also researches in the field of psychology, management, and organizational psychology, and behavioral science, positive psychology, and counseling psychology. Over to you, Professor Abha Singh. She's going to talk about emerging research trends and scientific practices.
Well, thank you, Professor Raghu. And it's a great honor for me to be here today with my co-panelists. And I can see the kind of work they have done is amazing. So I'd like to highlight my experience with you. I'll just go open my slide. Just give me a second. Can you see my slide? Please let me know. Can you see
Yes,
my
we
slide?
can see. Yes, Abha, we can see.
Thank you. So I think I would like to quickly give you insight, and my mission as a psychologist, an academician, a researcher is 3 Ps, that I promote mental health literacy by preventing mental health problems and promoting positive mental health. So I have a slogan for myself and my mission, which I do, whether academic, research, training, or community mental health. I'd like to elaborate further. Now, if I think I don't have to tell you mental health literacy has been debated and discussed last 2 days, so I just skip this. Here again, I like to invite attention of Professor Raghu that we are promoting in the context of mental health literacy on 6 domains. Yesterday we discussed on that. I would like that we have to have our attention on how to prevent mental health disease as well, because recognition is not only prevention. So we have to have a very strong domain added to it so that we are able to promote positive mental health and recognize early and use language very simple to communicate anxiety, as mentioned by Anisha. I agree with you on this. So this is very important. The model which I was seeing in research, very less research is done. So I found this model very effective, that how we can understand mental health literacy. Because as a scientist, a researcher, scientific way is important. And I'm happy that all co-panelists, they mentioned that way they have done their work, it has a scientific approach. These are models which talks about how we can use mental health literacy, and it's basically depicting about depression and how this is a major problem. And India as a country, we know it's already a pandemic and we are a depression country, as sometimes it is also stated like that. So now coming to the recognition, here I would like to draw attention that how your knowledge about mental illness and knowledge of prevention and promotion of mental health is very important. So this is the area of concern which I carry along when I see students in school, colleges, university. They are not knowing what is happening in their mind, how they're going through in their personality and behavior. Nobody's understanding in the environment. So I don't know how we are going to come out with some scientific models which can be very holistic to take care of the mental health issue of students in the campus, school, home, society, and many places. Going further, I'll I like to talk about, this is a research which I found minimal research, and hardly, if you see the increase in last 5 years. If you see the data here, year of publication, it was very low, but now it's a good sign that it has increased in mental health literacy, the publications. So it indicates that there's a scientific way to look at things, and we can reach unreached. This is one which I really want to inform the audience that how we need to reduce stigma. And I was hearing LiveLoveLaugh Institute, MindIndia Institute, and Kaustubh, all of you and Sangeetha, you all have done so much great work to reduce the stigma. But we need more institutions to come in, how to improve mental health literacy. And my again focus as a psychologist and as a researcher and academician is early identification and intervention. Here we are lacking a lot of good models, how we reach and how we can have a cultural conducive model, community based model, local based model, and where government and private sector, college, university need to work hand in hand to find solution to these problems and promote mental health in this unequal world, where this year mental health theme we already know is something which is alarming, the accessibility, the affordability of mental health at every level. Basically, the lowest level, the lowest strata of society, which we are talking of rural India. Now, if you see, I think top 10 countries in publishing research documents on mental health literacy, Australia and US. I'm happy to see India also there. So that means Professor Raghu, your team and the many universities who are working in this area, they are creating an impact on mental health literacy. But I have a question. Are we reaching to the unreached? I see the Kerala model. I'm so happy. Can be replicated in all states. So I did this study in 2018 with my group of students, evidence-based community program mental health awareness campaign in Uttar Pradesh, in a UP state in India. And this was, you can see 3 to 10th October 2018. And that time was young people and mental health in a changing world. Very interesting data came up. Objective was to create awareness and find some sustainable model, and also to assess, I told you the scientific way, assess prevalence of overall mental health needs in the community of that Noida area where I am located. We reached 10 villages. I'll go ahead. So major step in the procedure, it was a survey method I used with my team. And how first step was community mental health awareness campaign witnessed by 2,655 individuals and performed by 24 psychology students. So I'll go later detailing. Then data on mental health survey collected from 544 witnesses and 317 non-witnesses. So we divided the categories in non-witness and witness after this street play, which was conducted by psychology students, and you can see on the screen the name was Salah, and it was done in Hindi in this UP belt of 10 villages, and data then analyzed based on the findings of the survey analysis, and also the key outcomes from survey inferred at 2 levels. That was one within witness group and between witness group and non-witness group. And another very important point I drew in this particular research was qualitative analysis of experience learning of students of psychology, how they are experiencing and enhancing the skill. So you can see the participants number here right now, and the division which I had done community and the students of psychology. Because if you are involved as a street play you are conducting as a psychology student, what is your learning to deal with community-based mental health issues? So you will see very interesting finding which we got. And then we created awareness for mental health at community level, developed a sustainable model for community mental health, and then students of psychology, how they, through experiential learning, they enhance the skills of community mental health management. That was very interesting, we found. So the survey was in 4 parts. If you see on my screen, I hope it is visible to all of you. And this 4 part, first part was part A, where we talked about demographic analysis of our survey, that who were our participants and how we had managed this big crowd and how we each step was important for us to come to some indicators of our research. And part B was within witness group analysis, part C was between witness and non-witness group, and part D was qualitative analysis of experiential learning of psychology students. So you can see the questions. I do not have to that's my time to read every question. So did you witness? So this is the data of Nukkad Natak Salah, that percentage you can see on the screen. Then any member of your family suffering from mental health, what was the answer? Then are you a participant in community decision making? Do you consider your community opinion taking your personal decision? Very interesting. Is your community opinion of significance to you? So you can see the percentage. What techniques you use to relieve your stress? So you can see on the list that how understanding of mental health and tackling by talking and also by taking help from community. Then we did statistical analysis on the witness group. N was 544. Then you can see the mean comparison of mental health awareness campaign witness, and it is, you can see the histogram, and this is the man Whitney. We try to compare both groups, and basically if you see how they were trying to understand the difference between the awareness campaign, those people who witness the internal shame, the shame which is given by people, so how they try to relate it to themselves. That was something very, very, I think, amazing thing we found within the 1 hour or 2 hours in each village. And comparison was, it was significant. People were able to find some relevance who had witnessed. So part D was how psychology students, they really learned certain skills and how it made difference to them in their approach, in their sensitivity, in their listening to the people's concern through their street play which they did. And also the general view which came out on the general attitude towards how they look at the mental health problems, not going through only through the route of black magic or the tantrics, and the people who are not professional, they understood from that street play that yes, this is not the way, and we have people who can help professionally in that context of our mental health problem. So in the end, if you see, the key outcome of enhancing mental health in rural areas is something very important for us to look at, that if we are able to reach community-based model, this was a community-based model of UP. So it's interesting to look at all villages nearby of the university when we reached through this street play and had this survey question. We found that they were able to understand at least what is anxiety and how when they have some kind of mental health issue, they should reach people and not they have the kind of attitude towards health problem as issues as others, but it is also equally important for mental health problems to look at in that situation and how to tackle the general attitude towards people in the community, in the village, which they have. And then the kind of shame was something, internal, external shame that they associate with mental health issues, the problems with the social stigma, which we discussed which was discussed by many panelists. And also the internal shame, which reflected self-acceptance, self-regard, and positive self-awareness for their problems, which they reflected in that survey, which we found. And it really gave an indicator to us that how need for counselor in village settings are required. Students studying psychology, PG, UG, they can go to these places. Rather internship, they are doing different places. They need to go and help by the training which they get from their professors in universities and colleges, so that at least some kind of awareness and acceptance of those people of rural background, they can get help. So these were my findings on this only 10 days, 3 to 10th October, you can hardly 7 days, 1 week work we did, 2018. And this model was appreciated, and this was done by district collector cooperation. And we had that slogan of Swasth Man, Swasth Bharat. And that is how we tried to reach. And people usually linked with that slogan, and they were able to reiterate and understand the importance of mental health. So, overall, this program on mental health awareness campaign and survey analysis, which we did, indicated the evidence based community program, and it showed that yes, it can help not only in mental disorders, which is we talk more often, but also to identify early anxiety and depression and give them in a simple language. Truly, they understand, relate, and they are able to take action, because we know mental health literacy means we have to make people aware, psychoeducate, and at the same time, we have to also take action. So, with this, I come to end by managing my time, whatever I had. So, I believe that healthy mind is strength of self, family, society, nation. And that's how the slogan of this project was Swasth Man, Swasth Bharat. Time has come that this literacy project, Professor Raghu, which you are taking initiative, should spread whole India. And all my panelists, Anisha, Sangeeta, Kaustubh, and the kind of work you people are doing, I'm sure that we are not far behind to promote more positive mental health, not only focusing on clinical aspect that there is a disorder only, but there is also an order of mind. And we have Indian approaches. I keep on talking on that meditation is a cure with the help of meditation. Time has come. The time is right. Thank you.
Thank you. Thank you, Abha.
Anisha. Thank you, Professor Abha Singh. It was an excellent presentation in relation to how the importance of mental health literacy in the Indian context and the little studies that you actually put forward provides that information for us. So I think I came from the premise of mental health literacy, and I think through the 3 years I've learned that mental health literacy is not a unified concept. Mental health is actually mental health literacies, and I think there are various ways in which how people generate that mental health literacy. So can I also invite Professor Asha Banu to the stage as well, please? And then we will briefly take some of the questions. I think, apologies for the time delay. I think it is giving an opportunity for us to get the whole information and enabling people to discuss those themes. I'll take some of the questions. So one of them was actually, how important is it for people to be aware of the purpose of psychiatric medicines, the brain biochemistry, and the side effects of medicines? It is also a part of the mental health literacy. Are they well researched, or alternative medicines apart from allopathy that can improve prognosis among people with mental health problems? The two doctors amongst us. I'm sure. I think I'm going to direct this to Dr. Mangala and Dr. Kaustubh. For this, if you could quickly come back to that, those questions, please.
Yeah, that's an interesting question, Dr. Raghu, but then it is a double-edged weapon. It is good for people to be aware of the purpose of psychiatric medication, the biochemistry, but at the same time, too much of information about what the side effects can be a big challenge for the prescribing psychiatrist, handling questions. In some cases, I think it is very essential that they are aware of some of the side effects, but then they tend to overdo, because I think they're all taught by Dr. Google. So it becomes a big challenge when we have to handle those questions. But I think it keeps us also aware of what we expect in a patient when we are prescribing a medication. So it is good and bad. It's very difficult to take a stand there. I don't know what Kaustubh has to add to it.
No, I think I will add to the second point of this question. Maybe the first question, I think Dr. Mangala answered by you. I don't have anything to add. So for the second question, I think we have enough evidence for other approaches than medicines. We have enough evidence for psychological approaches. We have enough evidence for social care approaches. And just to summarize, I think any mental health condition, recovery from any mental health condition can't be possible without only with medications, and can't be possible without psychosocial approaches. So I think recovery has to be seen as a holistic recovery rather than just a symptomatic recovery. So these are my few points.
Yeah. Thank you very much for that. Thank you. There's another question in relation to, I think this, how did building a digital space in mental health in the Indian context differ as compared to the traditional mediums of mental health awareness? May I direct that to Anisha?
Sure, absolutely. So I think it's really important to understand, like I said in my presentation as well, to understand the audience you're talking to, and within the audience, the age consume digital media. So, for example, the lecture series event that I was talking about, we are very specific that the age group has to range between, say, maybe 18 to about 40, which is largely the target audience of our digital platforms. But the way an 18-year-old consumes information and the way a 40-year-old consumes information is very different. And so we had, one entire conversation, which was about 45 minutes long. In all probability, anyone between the age group of 30 to 40 watched the longer video from start to finish. Some of the younger age groups, so 18, 20, 22, I think I don't think they had the capacity to watch such long format videos, and so we just took that out and made very, very small, 2.5 minute snippets, back to the to the main conversation. So that's just one example. I think to answer the question, it's important to understand the age group, the target audience, what you really want to achieve. And largely that's how it differs from your traditional forms of information.
Thank you very much for that. Thank you. Another question for Dr. Mangala. Can you reflect on what kind of change you see in the mindset of family members, caregivers, and neighbors, and spouses and in-laws of people with mental health problems from the time SCARF was initially started? So it's a long reflection for you.
Oh, yeah. Yeah, that's a very interesting question. Yes, we definitely are seeing a lot of change in the way people approach mental health now. It's a very encouraging sign. We still see people who have long durations of untreated illness seeking help, but at the same time, we also see people who seek help within 3 or 4 days of onset of some change in the behavior. So, which we think is definitely a very encouraging sign. People are able to accept and seek help. But talking about the reservations about help seeking, uh, we definitely see that there is a lot of there is more stigma in the urban areas than in the rural areas, where I think acceptance of mental illness in the neighborhood it is not no big deal. They accept the fact that somebody is unwell and he is embraced as part of the society, and he is treated more with sympathy. Maybe they don't take initiative to treat him or make him better. That still continues in some areas, but then they are able to accept that person as an individual and are more tolerant. Whereas in the urban areas, I think there is a lot of stigma. People try to hide the presence of illness under a carpet until everything becomes very unmanageable. They don't want to see a mental health professional. And I think it's fashionable to say call everything as depression, because that is very easy and more acceptable. I think that's a good sign. It's okay. There is some mental health condition that they are able to accept as a diagnosis. Maybe schizophrenia is difficult, but if they are able to accept it as depression, we are fine with it. But there is a definite improvement in the way people look at mental health now. But is knowledge improved? I'm not so sure, especially when we look at some of the conversations that happen in the social media. It's pathetic. The perception about mental health, their observations about mental health related issues, and the use of words, derogatory words, when it comes to mental health service users. I think those are all things that need a lot of change to happen before we can call ourselves as mental health literate.
That's right. Thank you, Dr. Mangala, for that insightful reflection from your work. There's another question for Dr. Kaustubh. Um, what were the challenges experienced in getting the community members to agree to participate in the Atmiyata project, and how did you overcome it?
I'll try to be brief. It's a long question. Thank you for this question. I think the first biggest challenge, because we are going ahead with the volunteerism, the first biggest challenge is asked is whether there is a payment involved for this work. So that's the first challenge. And from our ethos, I think from the start, when the facilitator goes into the village, start introducing the intervention, start talking with different leaders of communities, we were very clear that there is no direct payment involved in this. Obviously, there are a lot of other benefits which the champion or the volunteers get. Is about training, is about being more visible in their village, increasing their own credibility, and so on. So I think that's one of the challenge of having that, continuing with that volunteerism as a ethos and as a work ethics. The other challenge, I think, is in finding people, is largely from the different, I will say, from the different social backgrounds, largely from the caste perspective, as well as from the class and the gender perspective. And that is why we intend to do a very in-depth village mapping. So we actually spend almost 2 months in a village. The facilitator spends almost 2 months in a village, each village, to find the right person. So that is how you can see that we try to mitigate this strategy. So that's the solution for that. And the other challenge, I think, is keeping up the motivation. But I think that's across the all the projects, that how do you maintain motivation for people who are working, largely the frontline workers. And we have our own ways of dealing with that. Uh, for the challenge, but for this question, I think these are my two things. That is, first is the volunteerism, which we continue to face, as well as finding a right person.
Thank you, Dr. Kaustubh. One final question. Are there any organizations that work on reintegrating people with mental health problems in the workplace, and train them for improving their chances of being employed in mainstream full-time job? I think
Yeah,
Scarf.
yeah. I think I can take that question, Dr. Raghu. Yes, SCARF has always been involved in rehabilitating, especially finding employment for people who are under our care. And we have identified potential employers with whom we constantly are in touch, and we send them well functioning patients from our rehab center whenever there is a vacancy, and we keep a track of how they are performing. And the employers also are very understanding. They are aware of mental health challenges that people can have when they take up a job for the first time. That apart, we also had a couple of job fairs. I think the pandemic has put a pause to it. We intend to resume it again in the coming years. So we had a job fair when we had about 10 employers who were willing to come and interview our patients here, and we made them write their own profiles, get it ready, and we circulated it. And besides that, we also arrange for our clients to participate in other job melas that are happening for persons with disabilities. Again, in job fair for persons with disabilities, mental disability is definitely not priority for any employer who wants to offer jobs. So there again, it's our team which goes and talks to those people, explain to them that how they can be employed. And in addition to all this, we also give away awards for an award for employers who have provided maximum support for people we have referred for jobs. I think all that helps us to get more people employed. And we also work with employers for patients who are already in employment. In fact, there are several instances of where these people are in the verge of losing their jobs, and social workers have gone negotiated with government officials made them accept that this person can be reinstated after he is declared sick by a board, so that people don't lose their jobs, especially in government service. So there are a lot of such activities which happen on a case by case basis. Maybe we do not have anything very specific for doing this, but then anyone who is under our care, we try our level best to make them occupied in some way, either voluntary or a paid job.
Okay.
And we also have employed some of our clients in our own organization, and SCARF has been awarded for as being the best employer for persons with disabilities in the past.
Yeah. Thank you very much for that. I think that is a good track record in relation to your work over the years in terms of looking after people and also bringing people in terms of back to work and other contexts as well. Thank you very much. I think I have to, we have very limited time, so I would try and conclude and also have a final word from Professor Asha as well. This, first of all, I know it has been an excellent presentation, a diverse range in which how we actually promote mental health literacy, some of the work, and I think that diversity is the richness of it all. And I think that there is no one way of actually doing it, and different ways, and how we all bring together. And I think what MeHeLP actually believes in is actually having that collective thinking, bringing everybody to a space where we can actually have a meaningful and a discussion of mainstreaming mental health conversations around it, be it from different dimensions, be it from the Western psychiatric models or from the spiritual models or for any other models that we can actually think of. So it was a pleasure to actually share this session with you, and also been a pleasure to having you with us. And this important discussion, great depths of knowledge here and practices that we can actually take on and lead on as examples. So many thanks, Anisha Padukone. Thank you for accepting our invitation. I know it's taken a long time for us to get here. Thank you very much for Kodayan. It has been great to actually have you. Thank you, Dr. Mangala. Thank you, Dr. Abba Singh. Thank you, Dr. Sangeeta Goswami. And finally, thank you, Dr. Kaustubh Joag, for Kaustubh and I, we have been sort of emailing for other things for the last few years in relation to many other things as well. So it is nice to actually have you all with us in having this conversation. And I'm sure we will be meeting again sooner in terms of our promotions. The final word from Professor Asha Banu.
So thank you, Raghu, for the chairing and also for allowing all the participants to take their time because they were sharing their passion and commitment, and that's the similarity. Also, this panel covered India in a way because I see SCARF from the southern part of India and Dr. Sangeetha speaking from the northeastern, but looking at eastern zone, and Dr. Kaustubh and Anisha talking from the western part of India, and Abba coming from the northern belt. Interesting work, diverse perspectives and different strategies we have learned, and also the target population each of us are covering, starting from youth and addiction to university students to and working with marginalized communities. So very interesting to see diverse models, perspectives, and also the different stakeholders that we are connecting to is very important. Learned a lot, and also I can see chat very vibrant. I thought that by 7:50 people will get very restless, but then people are there asking questions and thanking. That also shows everyone is showing a keen interest in mental health, and everyone has started discussing, and it's time to really move forward, as Dr. Raghu mentioned, in a collective way, and it's a collective responsibility. So with this brief note, we will say bye-bye for now and connect tomorrow. Thank you so much. Yeah.
Thank you.
Thank you very much indeed.
Thank you, everyone.
Thank you.
Thank you. Thank you. Bye-bye.